And so as we get started, again, I want to appreciate everybody's taking time today to come to the B3T Health and Safety meeting. Last few sessions we've had have been very productive around community discussions about what people want to see with respect to policing in the community. What they want to see is with respect to like budgeting and things like that. So this has been very good conversation. Today, we would like to focus a little bit more on community health and what sort of things we can do to improve the health of the community as we dive deeper into this work, because ultimately what we would like to do is to put recommendations on paper as to what we want to see come from this work from a health and safety standpoint. So just right now, we're still gathering a lot of ideas and collecting issues from people who are from what they're seeing in the community as a result of the pandemic and then the protest for racial justice. So that will be today's focus with respect to community health. And Michael, do you want to share the agenda now? Did you have anything you wanted to say?
No, we will be taking up, like you said, Kendall, health issues today. We've kind of narrowed everything down to access to health and access to health care and overall health care in the community. And next week, or I'm sorry, the next meeting, we will be discussing more of the safety features. We'll be taking a kind of a different approach with the SMART approach, with SMART goals, using the SMART goals. And the facilitators will be taking us through this. The SMART goals are SMART, specific, measurable, achievable, realistic, and timely. And we want to get as many recommendations as possible. So, be sure and participate. And we appreciate your attending each of the meetings and sharing with us your wisdom and knowledge and expertise. So this is, let me share with you the agenda for today. There we go.
And Michael, while you're sharing that, if we look at the breakout sessions and the two recommendations that are being asked, do we have any specific information as to any impediments to access to healthcare or what's causing health disparities in the community? You have any thoughts on that?
Well, I think that's something that we can all discuss. There are a lot of factors that go into reasons individuals in the community do not have access to quality health care, and most of the individuals on the focus team know these. And if you would just note those in the minutes as you are taking notes, anytime we can alleviate impediments, that will be a plus. Same thing with overall wellness in the community. So, just use your expertise, your knowledge, your experience, your strengths to add to this conversation. And we will get some good information, and we'll be able to put it in a one overall document that we can present to the leaders.
If there's no other questions or concerns, we want to go ahead and go to the breakout groups, Michael, so we can get started.
Okay. It looks like you and I are the only, you're the only co-chair that's present.
A few of them had excused absences today.
Yes. So why don't we just, this is a manageable size group, I think. We'll just do that. If we get others that come on board afterwards, then maybe we can break out a little bit later. Is that okay, Kendall?
If that's okay with the group, I'm fine with that. If anybody has an objection to that, please let us know.
And I can, I'll take notes. Is that all right with everyone?
Yeah. A couple people in the chat said okay, so.
Good, all right.
Let's go ahead. And I'll be assisting you taking notes as well, Michael.
Okay.
So if you can, again, share those 2 recommendations with the group and we'll get the conversation started.
Okay.
So based on what you know, where you live, the history of Louisville and the community, what are some of the recommendations individuals have that will increase access to healthcare in our community?
I think we have to be willing to market healthcare professionals to come to the community. So I was telling Michael earlier, in the 2100 block of Chestnut, Creative Spirits is moving their whole organization to that block. Their address will be 2100. It's a Black-owned BHO. They'll have access to substance abuse, mental health, domestic violence. They'll even be doing perpetrator intervention. So they were willing to come down. So I think we're going to have to market people to come down to West Louisville to offer their services.
So Kim, if I can follow up with that statement you just made, you know, getting the individuals down there, getting them present, getting a brick and mortar building or whatever they're going to be housed in. A lot of times investors and developers want return on investment. So what are some recommendations that you may have that will allow people to get the return on the investment providing healthcare services?
Well, the person that purchased the buildings over on Chestnut, very wealthy, did not want a return on her investment. She wanted human capital, and human capital is the lives of other people getting better. So that's one of the things that she looked for. So I get it that investors want a return on their money, but I think we're going to have to tap into people who want human capital, who want to see the lives of other people improve, just based on them investing their money and not receiving a return.
Hi, this is Kathy Johnson. Can you hear me?
Yes.
Would this be an area that we could try to get a grant from some nonprofit that is interested in this area? I know Bill Gates Foundation is very interested in healthcare, and maybe we have to be able to offer somebody some financial incentives for moving their offices into the neighborhood.
And do we know how much Bill Gates or someone like that is willing to give for this sort of thing?
No, I really don't know that. I'm just thinking there's got to be places that we could apply for grants, and specifically, make it very specific, as in the SMART outline of what we're looking for and what it would take. We'd have to query some of the physicians to see what it would take to get them down there, to get them to move into where they're most needed. And it just seemed to me that that was a ripe spot, opportunity for a grant.
Kellogg also has grants, similar type grants.
This is Denise Sears.
I'm sorry.
Oh, I'm from SOS. So one of the things that an important step, I think, is to take inventory of the services that are already going down there that are responding to the need and the heightened awareness and the publicity, and making their move now. So I know Norton is planning more facilities down there. I heard U of L. And there are some others that I know have come to us seeking, supplies and equipment to, to open, smaller clinics. The challenge, though, is there's no footprint so that there's coordination, and you could end up with a concentration in one area and a desert in another. It'd be really great if new facilities somehow could kind of had somebody to check in with. One of the things that I've talked to Norton about is there are grassroots community started and community run clinics in West Louisville, and they need to be respectful so that their efforts to bring healthcare to the community don't undermine an existing clinic. So I think, to talk about grants, et cetera, you've really kind of got to take an inventory of exactly what you have and where it is. And I mean, I'm not aware of that asset being out there, because it would be helpful to me if there was such a thing, so that as groups came to us seeking our assistance, we could guide them geographically to go where there's the greatest gap in services.
I agree with everything Denise just said. There's groundwork that needs to be done, and having a survey of what's available probably step number one before going any further. Because you're right, most of the times there's places that are ready to work and nobody knows that they're there. So the other thing is the Greater Louisville Medical Association, they have been doing a lot of things, including starting the Healing Place and having some of the doctors do clinics at some of the churches. So it might be good to partner with somebody like the Greater Louisville Medical Association or the Kentucky Nurses Association.
Hi, I'm sorry, this is Gina Von Rondo, and I apologize, I'm getting on the phone call a little bit late, and I was able to hear a little bit. And I'm an internal medicine physician, and I was born and raised in West Louisville. And I just started a business called Global NC that has the goal of improving the health of West Louisville. It's a mobile internal medicine practice. And I would love to have data and all those types of things, but for me, I just wanted to just kind of get out there and what I could for our overall community, which actually serves me because most of my family lives in West Louisville. I don't know if anybody else is doing anything like what I'm trying to do. And I did hear the young lady talk about someone who had a lot of money and just wanted to invest in just a human capital. And I completely understand that, but at the same time, I'm a single mom.
Giovanni, you're breaking up.
I don't have a whole lot of money, so I think just trying to find a way to be able to have businesses in West Louisville and actually make money. What I want to do is not just, of course, make money, but I want to make sure that, people are serviced and that other people can.
And to that point, I'm just
have a certain amount of,
Giovanni, you're breaking up.
Michael, there in the chat, there's several comments about telemedicine, which I think is also critical as well. So I made a note of that, but I think Mr. Porter, you've been on unmuted. I think you wanted to say something as well.
As I told Michael earlier, I was using Mike Porter's system last night on Zoom to do a public safety meeting for Douglas Hills. And when I signed on today, I'm apparently still using his system. So this is Jeremy Wall, not Mike Porter. But yes, I sent you, and I think you sent Michael both a copy of an email. I created an email several weeks ago that I think comes into play right here. And it's, what's the problem? I look at increased access to healthcare And I think we can probably talk all day about different options, but if we don't know what the problem is that's creating the lack of access, why aren't people getting health care? How do we figure out the solution? So we can do all kinds of things, but if it's not resolving the problem, then how do we do that? If transportation to get health care is a problem, we need to identify that as a problem. We can identify access. If having health care available in the local community is the problem, then we address what can we do to have health care access in the local community. Now, unfortunately, I am not as familiar with what goes into these problems in some of the West End. I haven't worked down there for a long time. I am in the East End. And I know that out here we're having some problems. The fact that Metro government has closed out our health department facilities in this end, and Metro government does not provide ambulance service in the East End of the county. Those both an impact upon the health care access that people in the East End of the county, and we have one county. It's not just the West End, we're looking at the entire county. But how do we determine the solutions if we haven't determined the problems?
And to that point, when we're talking about government stopping specific services or something like that, is an issue of resource allocation and resource availability with respect to like the budget. So one thing I'd ask everybody to think about is, you know, how this gets paid for, whether it's through government or through a private company, whoever does it, where the resource in the financing and the capital sources will be.
This is Abby Drain, 7 County Services. We are already located with behavioral health services on Broadway at 22nd and 26th and on Crumbs Lane. It's important to us what goes on in the West End and the South End, and what we believe in is integrated care. So the ability to wrap around healthcare and behavioral health care and addiction services. So I'm interested in this committee saying, are we in the right spots in West Louisville? Do we need to be in different spots? And how can we respond as your community mental health center? And as we move into integrated healthcare, those could be some more options for our community members.
As the conversation is emerging, it seems to me that there's a couple of data points that would be helpful. One is to identify what are the healthcare needs that are not being met, and what are the healthcare resources that are currently be available, and is there overlap, is there gap? Clearly there are gaps, but you know, to my mind, thinking about moving towards finding a funding stream or developing SMART goals, it starts with what's already available, what needs to be available, and how do we close the gaps. One model that I'm aware of that I think may have some value for us is a model called Meaningful Access. It developed primarily out of work to make sure that services and resources, primarily in the mental health arena, are made available to immigrants and refugee communities beyond translating a brochure into Spanish or making sure you have Asian folks on your website. How do you meaningfully make sure you are connecting with the audience that you're seeking to serve? There's actually a framework to look at what are the elements of a meaningful access, how do we develop our services in ways that are meaningfully accessible to the communities we're seeking to serve. That framework and the self-assessment tools that are attached to that framework may be really helpful in us thinking about what are the recommendations for increasing access to mental and physical health as a part of this SMART goal process.
Hey, Russ, did you just email us that model? Is that what you just emailed us?
Yes.
Okay, all right, thank you.
Well, that was a specific version. That model I sent you is one that's adopted specifically for male victims and how we make meaningful access to male victims. But the elements are there, and so it would be relatively easy to tweak.
So it can serve as a template to what it is you're talking about then? Okay.
This is Denise Sears again. Another thing that we need to do as we look at not only what resources are needed, but how to bring them in, is to ensure that we are looking at it from the eyes of the community and not from our own bias. So for instance, there is only one clinic that I'm aware of in West Louisville that is open past 5 o'clock. If you are working and relying on public transportation and have to pick up kids at a community center and you get there and one of them's sick, you have one choice at 26th and Broadway at the Hope Wellness Center that I'm aware of that's open past 5 o'clock. So the groups that are coming in have to demonstrate the sensitivity to what the needs of the community are that are specific to West Louisville, and not be assuming that what works on the East End works on the West End.
This is Lisa Bellafato from Passport Health Plan by Molina Healthcare. I just wanted to build on a lot of the great comments that have already been said, including what Denise just talked about. That I think it's really important. I think we, like Michael said at the beginning, we all could probably come up with what are some of the barriers to healthcare, but does that match with what the community needs and how the community would view that? So I think it's really important we start there, get that sense, and get the community involved with it. I think Giovanni said, she has I think she said it was called Mobile MD. Like, I'm sure there's some really awesome things that are out there already that maybe we can invest some time, money into that instead of necessarily starting from scratch. Like, so kind of going back to what everyone said, like, what's our needs, what's out there, what we can look at. I was on a project with Dr. Ryan Combs from Louisville's School of Public Health and Information Sciences, and he worked in West Louisville. We did a campaign around depression, and one on asthma and one on HIV. But the model was called Translation Boot Camp, or Boot Camp Translation. I might be getting them switched, but it was a very specific model and how it worked, where it had professionals, lay people, and community members that came together for like this 9-month period that really went through and and created very specific deliverables. Community members were paid for their time there, but it really, I got to participate in 2 of them, and it was probably one of the most impactful, and we got things done. Like, we just didn't talk about it. Like, we really had some outcomes with that. So that might be something to explore with Dr. Combs. I thought it was kind of a good model. And then finally, I work for Passport Health Plan by Molina Healthcare. We're going through our transition, but maybe getting the MCOs involved in some ways. I know Molina will have a type of foundation and some money to be able to invest in the community. I know Humana has their foundation. So, maybe once we have kind of that model of, what are the needs, what do we have, what do we want to invest in, what we want to build, that might be some areas where we can look for some resources.
Hey, Michael, this is Keisha. I'm going to jump in for a second because I want to weigh in here. So I probably have a very unique perspective on this because I'm a council person. I also came from the MCO world for Humana's Medicaid product. And then I also worked for Norton Healthcare when we deployed the mobile health center. So a couple of things I think we need to consider when we talk about access to care. One, and I'm a resident of West Louisville, so let me say that I had some concern around one of these original goals only because I have actually worked on the ground on this problem. The issue is many times we have to understand what it is, not just barriers that we see, but also cultural norms and what people feel comfortable with. So one of the things that we saw when Norton had their mobile unit, we saw a reoccurrence of the same population, not necessarily an expansion of a population. So one of the things when we went through to actually ask questions as to why we didn't see an expansion or why people felt comfortable coming back for the same services is really relationship. So regardless of whether or not you put an ICC or a primary care physician in West Louisville after 5 o'clock, if people don't feel comfortable with that doctor, and I'll give a really great, I think I heard somebody mention Giovanni Rondo, great relationship. But if you have a doctor that's down there who maybe doesn't speak great English or who doesn't know the cultural norms of that area, regardless of if that facility is open at 5 o'clock, most residents will feel more comfortable taking their child to the ER, where there are a lot more options for not only proficiency, but comfort. So just having an accessible healthcare facility or healthcare arrangements. I hope I got back on there. Sorry, I had an incoming call. Healthcare arrangement does not always facilitate nor mean that people will utilize those services. And we also saw that as I transitioned into Humana with their Medicaid product, that a lot of that has to do with comfort, education, and there's some cultural norms in West Louisville. There's some other things you have to consider. At 5 o'clock in the winter time, in West Louisville, if a parent doesn't feel safe, depending on where the location is even at, I'm going to leave my neighborhood where there's a perceived perception of a safety issue to go somewhere where it is safe to get services. So there are people who leave West Louisville just to go to other places, depending on their view of safety. So I think the lady who just spoke before me said, we really have to take some time to understand constituents' needs before creating solutions without really understanding what the community's barriers are. Even though we know it's an access barrier, we also need to understand additional barriers that we may not consider because we are not immersed in that population.
Thank you, Councilwoman. Lisa Tong, you've got a couple great quotes in the chat. I don't know if you wanted to expound on what you stated in the chat about like things like preventative care, and then you mentioned something about community input and consistency. Did you want to comment on that?
There we go. Hi, it's Lisa. Yeah, absolutely. The preventative care, I see that repetitively in the hospitals by the time that patients get to us. There are things that could have been addressed much earlier, and therefore providing that kind of access would be critically important, I feel like.
And if it's a cost issue for some people, because preventative care can be expensive for a lot of populations, do you have any ideas or strategies around how we can do that in a cost-effective manner?
Sure. One of the things that comes to mind is similar to what we do with like Surgeons Without Borders, where if you have a very specific program and you can get it to those who need it, you'll find that there are people who are willing to, one, donate their time, and two, there's others in the community who would be willing to donate money toward that if you're very specific about what it is that you hope to accomplish and you've done that background work. So I do think that's why the assessment is so critical, because people need to know where their money's going if they're going to give it to improve access and health in the community.
I think if I can jump in again, I think kind of in response to Ms. Dorsey's point, and this whole question about the assessment, part of the assessment in my mind would include, you know, where are people comfortable in going to access services? I'm familiar with other communities that have done some really innovative work of co-locating healthcare services, both mental and physical healthcare services, in places like barbershops or beauty shops, where folks tend to be more comfortable going. Barbershops, from my mind, from my lens, there's a lot more barbershops in our community than there are designated healthcare settings. Most folks go to their barbershop and their beauty shop on a regular basis, and they have a relationship with them. So looking at some of these other models around what would happen if would it make a difference to co-locate some of these healthcare services within those spaces where people go comfortably and regularly, whether or not they need a haircut. You know, some barbers are kind of hangout joints where people go and kind of chit chat and communicate and network. Would that meet the need? Some of the places, New York, Chicago, Detroit, are having some really good success in providing those kinds of services. I don't know if we know enough to know if that would be a meaningful approach here in Louisville, but I think it's worth exploring.
Yeah, I agree. This is Lisa again. I think that, you know, I can only use one example that we used I actually volunteered for in Southern Indiana, where we could actually go to the preschool and then provide some services. And I think that's something that was done years ago, and maybe that's kind of fallen to the wayside. But if families are going to be there with their children, and there may be an opportunity, as you've indicated, where you're going to be there anyway, picking up or dropping off your child, that if healthcare services can be offered in that location, it makes it more convenient for parents.
And to that point, Russ and Lisa, going into the community, like the barbershop example, one thing we need to be cognizant of is culturally, a lot of people don't want their health information being known to other people. So even if you're getting like a basic, screen, like a blood pressure screen or blood glucose monitor or something like that, we got to ensure privacy as well. Even if we are, hanging out, in our communicate or, communicable areas or whatever, let's just ensure privacy for people as well. One more from the chat. I think, Kathy, are you still on? You had a question about identifying health needs and resources to address symptoms. Did you want to say anything about that?
Just what I said, which is I'm sort of working backwards, which is we have these outcomes of these that seem to be symptoms, and then working back to say what is the health need and how do we meet it? And that's just because I think so that was it, just sort of working backwards from the outcomes to what's needed to prevent those outcomes.
And this is Charlotte Stites. I'm a pediatrician at the Smoketown Family Wellness Center. And I think these conversations are so important. And I think this idea of increasing access to healthcare in addition to the physical spaces, it is to help people understand, that they have the right to have respectful, affordable healthcare, and that the understanding and a broad sense of healthcare. So looking not just at the physical health, but using an integrated health model, including behavioral health, including food access, really letting people understand that they do deserve to have quality preventive care so that we can prevent this long-term diseases that are happening. And we are not demographically in West Louisville, but Smoketown is really quite similar. And some of the barriers that folks are facing is certainly we're here and we're open and we're available, but this understanding that they should have quality care in their community that is comprehensive, and how do we as a community work to improve not only the physical spaces, but the understanding, those as everybody has mentioned, these other barriers that we see with access to quality healthcare.
And to that point, Charlotte, I'm glad you brought that up. What I've been hearing a lot in the chat and with the communications that we've had with the councilwoman and other individuals is there seems to be a cultural barrier. It's invisible for a lot of folks, but there's a cultural barrier to some people in how we approach healthcare. For example, in the chat, Mr. Porter notes about things like prostate cancer and how it impacts African-American men disproportionately as compared to other groups of people. So what are some of the cultural issues that prevent people from getting access to quality healthcare? And I'm just putting this out as a question to the whole room to see if there's any ideas on how we can address these invisible cultural lines that prevent this.
Hello, I'm sorry, this is Giovanni Rondo again. And being in practice for going on 2 decades now, men do not want to say, African-American men particularly. I think education is very key, but again, like Councilwoman Dorsey said, having that relationship is just vitally important. So one of the things that like I'm trying to do or trying to be empowered to do is actually get more African-American male physicians and just African-Americans just overall to actually come into the community and to provide services. It's difficult. Like I went to medical school at U of L 20 years ago, and there were a number of us, and we have different people coming through, but they come and then they leave. So what's going to allow people to feel comfortable to, stay? What keeps them here in Louisville, Kentucky? What has brought me back, obviously, is my family and my connection here, being born and raised. So in terms of just prostate cancer, Norton has an initiative that they're actually going to be starting. I was just talking with an African-American male physician yesterday with an interview, Dr. Stephen Patton, and he is involved in their initiative about getting the word out about prostate cancer with African-American males and just checking the prostate overall. So I think that there's different things that are going on. It's just kind of getting it all together and just having maybe other ideas of other ways that we can get the word out. But to me, the key is relationships. So throughout the years, as I've developed relationships with all of my patients, I'm better able to convince them of things that are important for their health, as opposed to, especially during my first, portion of my career. As you have a relationship with them, you just, you trust them. You trust your physician more so when you have a long-term relationship, obviously. So we have to, just start that whole process. So, my big thing is to get physicians, nurse practitioners, PAs, who actually come from the community, and the ones who've left maybe come back and, and come into the community and really care and really provide healthcare services. So Park Duval, I work at Park Duval part-time, and so there was just a mention about no places being open after 5 o'clock. Park Duval is open after 5 on Tuesdays. I worked at Shawnee Christian Healthcare Center also, and they have a day, I forget what day, but they have days that they're open past 5 o'clock also. So, there's facilities that are out there, but I just think that we need, maybe a concerted effort, and we need more of African-American physicians to really be a part of the equation. I'm a part of Fall City Medical Society, which is a group of African-American physicians in both Southern Indiana and also in Louisville. And so we're trying to, put together things that really reach out to our community. So overall.
And Kendall, if I can jump in after Dr. Rondo, there's one thing. So I was part of the group, or actually project led the Norton Healthcare back in the day. I don't know how Dr. Rondo maybe remember this. I'm telling my age a little bit. Norton Healthcare did a men's health event. We did it almost 2 years in a row at Slugger Field. And before even kind of going down this road, the first thing I'm going to say is we did an extensive survey to really understand some of these things about relationships and barriers before even planning the event, which is how we got to the event. And part of that relationship is under the leadership of Dr. Sandra Brooks. For those who may have been around Louisville for a little bit, we found out that when the physicians didn't have the relationship, we could then leverage relationships kind of as a conduit. So we used Dr. Bernard Clayton, who has been very outspoken about going to Norton, and actually Norton diagnosing him through one of the cancer bus for his prostate cancer. And so we were able to translate the trust that he had with the community for men to come into that particular setting, to get testing. And we geared it around men. That was the whole purpose for it being at Slugger Field. And we used other male leaders. I think we had like the coach of U of L at the time, Dr. Heiser from Heiser Health Clinic. So we did a lot of research into that. I'm saying all that to say, I think if we reach out to some of these health institutions, I know for sure Norton, there were two major projects around healthcare and around ED diversion, because Norton was looking for ways to funnel people into ICCs and primary care to divert some of the high cost care that we saw coming into the emergency room. I'm sure if we reach out to them and kind of pull some of those lessons learned from those initiatives, it would give us a place to start and maybe increase the baseline so that we're not starting at scratch. And we can leverage some of that history of projects that have been done. We have gone into hairdressers and barbershops. So I'm hearing these initiatives, and I'm like, the American Heart Association had a whole program around decreasing high blood pressure and stroke awareness, and they use barbershop and hairdresser models, so we could reach out to them. I think part of this is knowing who has the history, a legacy history of this community, and understanding what work has been done, and understand of those initiatives, what worked and what didn't. And that would give us a better starting point, because part of this, I think, is fatigue for many healthcare professionals who feel like, okay, we're going back into this again. Because for me, I'm hearing the same old, and I'm only 35, but I've been in healthcare in this community since I was in high school, and it sounds repetitive. So could we do something a little different and actually go back to folks who have already implemented some of these things, start with the lessons learned, and then create a strategy moving from there?
Thank you, Councilwoman. Dr. Ronda, I did want to follow up with you if I could real quick. You know, a lot of pre-screenings and preventative care often have things that are attributed to them that are kind of, I don't want to say passe, but just there's something attached to them that just give people cause to want to go out and get pre-screened. For example, with the prostate screenings, it's the uncomfortable physical test that prostate tests have been known to be, basically. Same thing with like getting a needle stick or something like that. So I actually have two questions for you. One, how can we help people kind of overcome the preconceived notions of what an exam entails? And then two, into Keisha's point, if we're going to overcome cultural barriers, can we utilize like celebrities who would go put the gown on or go get the test done to encourage people to go out and get tested?
Absolutely. I think to your point, like that's why I mentioned having African-American male physicians come out and talk about these issues, because they can relate like no other. Like the two that I was interviewing yesterday, I do a show called Healthy Mind, Body, and Spirit with St. Stephen's. And so that's exactly what we talked about yesterday, is how hard it is to get African-American males to even come into the doctor's office, but particularly about the prostate exam. So Dr. Anthony Alexander talked at length about how he gets his family to have prostate exams, or why it's so important. So I think having that perspective of one guy to another, and making it so that just like I can, you know, talk about things for women a lot better to another woman, as opposed to trying to, you know, get a guy to do the same thing, or a gentleman to do the same thing. So, so I think that relationship is very important, or that association is very important. And so we do have a number of African-American male physicians who are willing to speak, and to speak on those issues, that I've been able to kind of partner with in not only the Greater Louisville Medical Society, but also Falls City Medical Society, and in other groups that I'm in. And then the second point, in terms of, I'm sorry, what was the second point? Sorry.
Kind of answered a little bit, overcoming like the taboo nature of what some of these pre-screens involve, and then using celebrities to get the point across.
Yeah, I think that actually does go pretty far, especially for the younger generation, younger population, or if you can kind of relate somewhat with that, you know, celebrity. I remember when Daryl Griffith did some things with asthma. So that kind of, you know, brought it out, and it was a celebrity, and it kind of stigmatized, you know, issues with, you know, the maleness, and the, you know, have issues with respiratory issues, asthma. So I thought that was actually, you know, a good, you know, celebrity point to bring forth. And I know other, you know, outside of Louisville celebrities have been somewhat successful in bringing different things about, more females, more so than men. So I think definitely if we can get some younger male, you know, celebrities to come out and to, you know, partner up with us, maybe we could, you know, make some leeway, especially with the younger population.
My understanding of the health of the data related to the effectiveness of those kinds of PSAs is that they are very time constrained. And so I'm seeing in the chat the the Will Smith's YouTube video or any kind of PSA campaign, there does, from my experience of the data, there does seem to be a bump in effectiveness in terms of increasing men for, in this case, willingness to go get tested, but it's only for like a 15-minute window. I'm being a little bit dramatic, right? It's only for a very short window. The PSA goes out for a day or two, maybe a week, you see a bump in increase. And then as soon as that PSA stops being visible, it doesn't sustain itself. And it seems to me that we're at a moment to look about sustainable change and structural change. And so, yes, I think there's, I don't say that to discount PSAs and that kind of outreach. I think there's a real value to it. And I think there's a need to think really systemically around what is the role of those PSAs, since we're unlikely going to be able to have a constant PSA online available for the next 10 or 12 years. We need to think about how does that fit into the rest of the campaign to increase accessibility to testing, as an example. I also know from my understanding, there's also a barrier. There's one barrier to being tested. There's a whole other set of barriers to treatment that exists for folks. And so then what are the other accessible strategies that we have to meet the barriers to treatment, whether that's mental health treatment or physical health treatment? As I keep hearing, I keep going back to what's the assessment? What's the problem that we're trying to address? And what's the and then we develop a strategy to address the problem.
Well, to answer your question, Russ, when I initially kicked the conversation off, it was about disparities in healthcare based on specific communities. We see through Center for Health Equity reports huge disparity in life expectancy for someone who lives in West Louisville versus someone who lives like in Prospect or someone like that. So that's the sort of data I use to kind of jumpstart the conversation. Also, to your point about the PSAs and in the 15-minute sort of fame window when somebody does a PSA, on the flip side of that, do we have to be careful about PSA fatigue? Because if we continue to harp on it, and people are like, look, I had my colonoscopy last year, you keep asking me if I did one, so I mean, again, I'm just having dialogue here. I'm not saying
no, I hear you,
good or bad, but those are
I
things
hear you
as well.
Absolutely.
There's something in the chat. Someone said something about greater influence. Charlotte, did you want to speak to that, please?
I'm sorry, this is Dr. Rondo again, and I just wanted to say something real quick. I think it goes back again to relationships, and I think that just building those relationships is just so vitally important, because even if they, PSAs get tired, whatever, if you have a relationship with someone that you see on a regular basis, if that African-American male has that relationship, they're much more likely to follow up with their colonoscopies, their PSAs, their blood pressure, the risk for diabetes, all of those things. So to me, trying to get those relationships established is just vitally important.
And maybe there's a way to, keep building on the community health workers that, I know are out there in the community and continuing those relationships. I had put in the chat earlier, maybe as a long-term goal, kind of like a pipeline, investing in education. So we are training people in the community to be the, next future of the physical and behavioral health providers for the community. So there's, building on that trust and relationships that are there. So I think those are some things that we can look at too.
I do want to kind of turn the conversation a little bit towards, we've been talking a lot about preventative care and what we can do to help prevent chronic diseases and chronic conditions. But to Russ's point, what if we get diagnosed with a condition, or what if we've been diagnosed with some sort of need for some sort of treatment or service? There's a cost factor and barriers to getting that service. So Russ, did you want to expound on that? And then I'll open the floor to people's thoughts about barriers to treatment.
I think this kind of runs more, and my lane is much more mental and emotional health than physical health. But there are, and again, from my background and my experience, primarily thinking about men's experience, if I can generalize to men as a community. But there does tend to be a different kind of willingness for men to be tested or assessed for their mental health needs. Not great, but more. Depression, addiction, behavioral health dynamics, and it drops off significantly in terms of following through with treatment. Part of that is from their own selves, but part of that is also structurally. There is a lot more accessibility to assessment tools, even as limited as they are, than there is to meaningful, culturally competent, culturally humble treatment. And so, there's whole, in my mind, there's a need to do some campaigning around people seeking the services that they deserve. And I think language is important. So I talk about the services that people deserve as opposed to services that they need. And then how do we make sure, again, that the services that are available are meaningfully available, which to me, as I understand the model of meaningful access, that includes being culturally accessible and culturally humble. That's part of meaningful access. And so, it's both looking at what is it that we can do on the individual basis to promote the kind of health seeking and health care that people deserve, but also on the structural level, making sure those services and resources are available to folks in ways that are accessible.
Thank you, Russ. Clay, I wanted you to speak on something you wrote in the chat. You are a survivor of a chronic condition. Can you give us sort of a Cliff Notes version of what you would be feeling if you didn't have like health insurance, or if you didn't have the resources to be able to get the treatments that you needed to get when you were diagnosed, and any strategies that we could utilize to overcome that barrier? Because I mean, that's very real for a lot of people. To Russ's point, you get diagnosed with something, and then you have to treat it, and there may be things that block you from getting treated. So can you kind of give us an insight into what you would do, given that you're a survivor?
You're muted.
I think to face the situation I was in with cancer and not have had the availability of medical treatment would have been devastating. It would have been something, how much longer do I have? How do I prepare for death? That it is coming. I noticed Rush Limbaugh said this past week that his lung cancer has reached the point that it is a death sentence. If I did not have that, and I was fortunate in that, having been on the police department, I had health insurance through the state retirement. Being retired from the Army, I had health insurance from the military. So I was very fortunate in that regard. But to have not had that, I cannot imagine how devastating that would have felt. That would have been both a physical and a mental anguish for me to have to deal with. Fortunately, we do have many resources. I'm not going to say we've got all the resources that are needed financially, but at least there are a lot of resources available. And part of my concern is getting, and I've dealt with this a lot, as I put in the text, I've been on the soapbox for 13 years. I am alive today because of early diagnosis. I do not have further with cancer because of early diagnosis. How can I, as an individual, contribute to getting other men to go in and be checked? Start out with a PSA. And if the PSA is low, probably don't have to even be looking at the digital rectal exam, the physical exam. But it's very minor. I mean, even the physical exam, even having to do a biopsy, is very minor to the concept of death. And that's where the trade-off is. How do we get people to overcome that reluctance? Men don't like going to doctors. I think that's almost universal. We don't like going to doctors, but it gives us the opportunity for longer life. We talk about the lower life expectancy of males in the West End. I think it's probably males and females. But it gets down to reluctance there. How do we overcome that reluctance? And we get into on a routine basis. go get checked. I found out in 1976 that I had a heart issue. That got me going to the doctor once a year minimum. Just go in, am I still okay? How do we get men and women to overcome that reluctance to seek that medical care? If we can't get them to seek that medical care, it doesn't make any difference how much access we've got. It doesn't make any difference how many clinics we've got in the various areas. We've got to get these people to walk through the front door.
Thank you, Clay. Craig Blakely, are you still on? You'd attached some table data, regarding socioeconomic determinants of health. Did you want to speak on that, please?
I can. In fact, I also sent 2 short pieces to Michael that if you want to put them in the chat and make them available to folks, that's fine too.
Okay, they're up.
Okay. Yeah, so you know, we were pointed in the direction, and Lisa kind of made reference to some of this earlier of talking about the determinants. Why is it that these health disparities exist? And that set of figures, again, I apologize for the way the table broke up, but it provides a picture of a lot of earlier down the road conditions that contribute to the life expectancy kinds of disparities that we see there. And, you know, from a population prevention perspective, clearly what one would want to do is look for markers earlier on that one could target sooner in order to try and impact, you know, ultimate outcomes. And so it's just a list of some markers that are, you know, really impactful social determinants that we all should be looking at targeting if we really want to make a difference in health status in the community, as opposed to simply just access to health care.
So this is a major structural change that needs to occur in order to make a more equitable health outcomes for populations.
Yeah, and there's groups working on every single one of these, but you know, we need to come together and make a bigger deal out of it, is I think the message.
And as we have this conversation, let's keep in mind, and Kathy just made a good point, Kathy Johnson made a good point, we're not only talking about going to a doctor or anything like that, there's also dental care, mental health care, the various things that you need to keep your body working and keep yourself healthy are also involved in this conversation. A lot of times dentists and dental insurance gets overlooked because some employers don't provide dental insurance, but dental health can go a long way in your overall health as well, as we've seen. And so, Kathy, did you want to say anything more about dental care?
Just that even middle-class people who have fairly good jobs can frequently not afford dental care because the dental insurance has not progressed like health insurance has. And bad teeth can make you sick physically, other parts of your body. So it just occurred to me that was something we would need to think about. The other thing I was just going to start typing was that we have to have buy-in from the community, because there's a natural distrust of sometimes of these kinds of institutions. You know, Tuskegee, Henrietta Lacks. You know, there's a reason people don't want to go to the doctor sometimes, because they don't really trust them, and you got to build that trust with the, and then you can get into the relationship of, you know, having confidence and feeling comfortable with somebody.
This is Giovanni again. So just on the dental note, I work at Park Duval, and they do have a dental clinic, and so does Shawnee Christian Healthcare Center. For what I do, I have the Global MD, but Dr. Kwame Watson actually has a mobile unit where he goes to different locations to provide dental health, and he's an African-American male dentist. So I think in some ways, what I'm trying to do is literally think outside of the box and trying to get specifically African-American men into the office. I remember when I first started practice, and the very first African-American male that came into my office after months of being in practice, I did flips. I was like, oh my goodness, I can't believe it. It was wonderful because it was so rare, you know, and he came in on his own without being brought in by his mom or his sister or anything like that. So I've always had that issue, and I've always had like a calling to try to get African American men. And so that's what kind of led me to get the Global MD, because if they're not coming to me, then I will go to them. I'll go to the different locations. So one of the first places that I went was a barbershop, just to do blood pressure screens, just, you know, just some basic, you know, stuff. But I think we have to start somewhere. We have to think outside of the box. We can't do the typical stuff that has always been done. So I think the ideas of, you know, people just thinking differently of how this can be administered is very important. One thing that I do also is that I don't even deal with insurance, because that kind of serves as a barrier for some people. And I just, you know, like to just directly deal with just the person instead of dealing with insurance and whether you have Aetna and here and there, because then they can dictate, you know, what you can do and what you can't do with, you know, all of that. So, you know, but if someone does, you know, have insurance and they, you know, they can go to other facilities like a Park Duval or like a, you know, Shawnee Christian Healthcare Center or whatnot. But I think that just the whole concept of thinking outside of the box is just very, very important. Having that relationship is very important. And I think that we need to look at just as a community, you know, just trying to make sure that we have doors that are opening for our children to look at the healthcare field as something that they can be a part of. You know, being a physician, being a nurse, being a respiratory therapist, all those types of things are you know, we can reach them. I can reach my community better because I come from the community. I know those things. So, so just really trying to make a big push, you know, for, you know, more diversity in the healthcare field overall, particularly in, you know, as a physician, and, you know, not just going out and, you know, getting this degree, but also bringing it back to the population that really, really does need it. Now, one of the things that I have looked at is, you know, just in my, you know, career, high blood pressure, diabetes, cardiovascular disease, and forgive me, I have a lot going on, I'm driving, and then depression and anxiety are like the big 5 things that I see the most, that has the most issues with mortality, morbidity, or whatnot. So those are the things that I really focus on, particularly in my practice. In the African American community, we don't talk a lot about mental health, but it's huge. Me bringing it up, I think, gets to the point better than someone else, you know, someone who's outside of the community. An African American male bringing it up, you know, he can touch those other African American men that much better. So, so I think, you know, I don't think that there's just one solution. I don't think that what I'm doing is just the only way to go, but I think it's at least something. So I think that just, you know, having ideas, thinking outside of the box, not just doing the same stuff all the time is really, I think it's key to really fighting, you know, the problems that we have with our community.
Kendall, you're on mute.
Can you hear me? Dr. Rondo, since we still got you on, someone in the chat asked, can we clone you because you're providing such great information and insight today? And then 2, you spoke on it just a second ago. There is a deficiency in people of color that are practicing medicine. So can you speak on like the importance of diversity training and equity training for medical providers, regardless of what their background is, in providing service to the community?
Absolutely. That is just vitally important. It's vitally important to be able to reach the community, you know, just in the best way that you possibly can, even if you're not from the community. Obviously, I speak the language because I was born and raised in it, you know, not quote unquote the language, but I know West Louisville very well, so I can kind of reach better. when I lived in New York City, I lived close to Chinatown, and just knowing a little bit of Mandarin helped me so much with some of my Asian patients that I took care of. So it wasn't everything. It wasn't like, oh, I'm Chinese now and I can do all this. But just knowing a little bit of the language and knowing a little bit of the culture was so very important. Like, you know, you don't, there's certain things that you just don't do, like, you know, in the Asian culture that I didn't know. And it's completely opposite of, you know, what we do in African-American culture. So, but just being aware of it, you know, just knowing it. And at where I went to NYU. And so they did have a couple of, not necessarily courses, but it was a part of the orientation for where we were, you know, close to Chinatown. So we, you know, it was just a part of, you know, knowing a few words. How do you say hello? How do you say, how are you doing? You know, that just really kind of, I know, made a difference. And I know that, and of course I was just a resident and we just saw patients really in the hospital, but I could, you know, but patients were a lot more willing to talk, and I could understand the culture better just by having, you know, that orientation in the you know, the Asian culture. You know, so that's just a kind of a different perspective, you know, from where I came from. But absolutely, I think that's vitally important, you know, just to know some of the nuances of the culture that you're trying to reach. There's a reason why, like, when I talk with my, particularly with my African-American patients, and I'll have maybe, you know, someone who's not of my culture, you know, dealing with them, like my medical assistant or whatnot, I try to let them know you don't address an elderly African-American patient by their first name for the most part. You put a, you know, you put a Miss or Mr. on that. And that's just a part of, you know, just one little thing that I know that I've had to do with some of my medical assistants. I've worked for the most part in Southern Indiana. I live and work here, but but a lot of times I would have, you know, lots of different people just come across the bridge, you know, to see me. But so I had to kind of do some explaining of, you know, the culture and why that's important to address them in that way, because it was disrespectful for just to call them, you know, Johnny or, you know, Laquita, you know, no, you have to put a, you know, a handle on that. So.
All right.
Anyway.
We've got about 45 minutes remaining in this meeting. And at this point, we're going to transition over to discussing recommendations for improving overall wellness in the community. So if we can come up with recommendations for things that will improve overall health in the community, whether it's access to parks, exercise equipment on walking areas, bike lanes, or whatever it is, if we can come up with things that improve the overall wellness in the community. Any suggestions on along those lines would be welcome at this point.
Well, this is Kathy Hinko. So 70% of white households own, only 36% of Black households own. So safe, unsegregated, affordable housing is a very big deal, especially if you look at the median income. If you are not worried about your utilities being cut off and your rent not being paid and your children not knowing where they're going to be sleeping from week to week, I think that is a base for being able to meet a lot of other needs. You know, if you are ever going to get to good nutrition by changing habits, and we all know how hard changing habits are, you need to know you have a home that you can rely on. It also means with this disparity in ownership, there's a disparity in having a sense of control in your life. There's a disparity in the sense of having intergenerational wealth to leave. So we want to get people stable and safe and out of the ghettos we've forced them into, but we also want to give people a future. And I think that's a huge issue in terms of improving health. So I don't have anything new to say.
Ms. Craig, again, that table that I sent earlier and those two pieces obviously speak to some issues, as we mentioned a moment ago, but I think we also absolutely have to have the reform efforts with the police department on this list. And I don't know if defund police is the right phrase. That's got so many negative connotations, but I think we need to support Yvette Gentry and what she's going to try and do in the next 6 months and be actively engaged in the selection of the new leader.
Any other suggestions on overall wellness in the community?
Michael, are you typing these on a list / would you be able to bring that up on your screen?
Yes.
I feel a little bit challenged in this question in that I don't know that I know or that we know what needs to be improved. So I'm going to go back to, my broken record of, it seems to me that a first step is doing some kind of assessment on what are the current barriers to the overall wellness, however we're defining wellness in the communities we're talking about. Obviously to Ms. Hinkle's point, the lack of affordable housing is one aspect. The policing issue is another aspect, but there's so many more. One, I guess, as I'm talking, I'm realizing how overwhelmed I get at the notion of where to start with the recommendations. But I just don't know that I haven't seen anything since Dr. Trautman has left that defines what are the barriers to overall wellness in the communities we're talking about. Oh, thank you, Ms. King.
Can I speak to that?
Yes, I'm going to agree with you there, and I come back to the point of we need to define the problem we're trying to address. I think of a lot of the western side of Jefferson County.
Can you speak up?
I was saying, can you hear me better?
Yes.
Saying of defining the problem, and that problem is multifaceted, in my opinion. I recall, and I want to make a comment about the west side of Jefferson County, not just the west end of Louisville, but the west side of Jefferson County, when I used to work in an area where it was not unusual to have chlorine gas leak from the Borden Chemical Storage Spot on Campground Road. And the pollution that occurred in that whole section of Jefferson County that has undoubtedly impacted upon life expectancy in a major portion of that county, of that part of the county. How much of it still impacts landfills that have just simply been filled over, and what kind of pollution, air, etc., is affecting the life expectancy because of some of those things. Undoubtedly, we have issues. I talked some time back with a social worker in Oklahoma City. She brought to my attention things about obesity and certain cultural groupings or people in certain cultural areas that tend to eat what they can afford to eat. And a lot of pasta, a lot of things that are relatively inexpensive, but are very fattening as compared to being able to eat vegetables and fruit on a regular basis because of the expense of buying those vegetables and fruit and things of that type that go into this wellness, improving the wellness. How do we define what we're talking about? Are we talking about retired officer, I will say I saw things on the police department. If it had happened when I was on military police, I would court-martial somebody for it. I will agree there need to be reforms, but what reforms actually impact upon the wellness of the people in the community? How do we define what we're talking about? Define what is the problem that we're trying to address? Air pollution, people's diets, how they cook and prepare their meals, lots of grease versus minor amounts of grease. What are we really talking about when we're talking wellness?
Can I chime in? This is Dr. Rondo again.
Yes.
Okay. The leading cause of death is cardiovascular disease. Okay? That is the overall leading cause of death. So you can break it down to, we can, talk about different ages, or whatnot, but still overall the leading cause of death is cardiovascular disease, and that's throughout our whole nation. And with the African American community, it's the same thing. Okay? So what contributes to cardiovascular disease? It's a plethora of different things. The two big causes is high blood pressure and diabetes. Okay? So if we want to look at the younger population, especially African American males, the homicide is huge. Okay? But if we're looking at the overall population, still cardiovascular disease is the number one killer. Okay? So attacking the things that contribute to that is most important. And that's why I focus on high blood pressure, diabetes, overall cardiovascular disease overall, depression, anxiety, because that plays a role in those things. Okay. So some of the suggestions that I have, and I think we have to kind of also go to people who actually live in the community. We're talking about all these things, but we want to also talk with the people who live there, who live in the community. So, and I have to admit, I don't live actually in West Louisville, but I still have connections there. Family members, my grandmother, 103, my brothers, my nephews, great nephews, and even have a great nephew. Anyway, so what I see that I've kind of been a proponent on is access to healthy foods, and not just access to healthy foods, but a drive towards eating healthier foods, and then how to actually cook them. I'm a part of an organization called Food Not Bombs, and we bring food from Whole Foods every Sunday to 17th and Magazine, which is in West Louisville, of course. So, and one thing that I've noticed, people pick they want the meat, and the heavier, the better, and they want a lot of the sweets. So the fruits and the vegetables are kind of left to the side, and but the more we do it, and the more we talk about what you can do with those fruits and vegetables, the more people are like, oh, okay, maybe we can do this or that, okay? So I don't call West Louisville a food desert. I call it a food swamp, because you can get food, but it's not the healthiest food. There's a lot of fast food. There's a lot of liquor stores. There's a lot of mom and pop places that sell a lot of things that aren't as optimally healthy. And I know, because I go there. I go to Indies. I go to White Castles. I go to Dino myself. So, so I'm not just saying for other people, I do it myself. But just making those places and foods not only more accessible, healthier foods more accessible, but more palatable, and things that people will actually go for. So that's a dilemma. Then the other thing is your physical activity. Now, especially during this time, COVID-19, people are, especially in the winter months, going to be indoors more so. But even when people are outdoors, people don't feel safe being outside. But actually having more green spaces is very important. Shawnee Park and Chickasaw Park are the two, green spaces that are available all the way far to the end. And there's other interspersed green spaces, but those are the largest ones. So just advocating more, trees being planted, more being outdoors in green spaces, just being outside. And that actually helps not only with blood pressure, but it helps with, your weight, of course. It helps you with anxiety and also depression. There's all these different concepts about what we call forest bathing and just being outdoors and hiking and what that does for your mental state. So that's something else, having more green spaces and just encouraging people outdoors more. But then we have to deal with the reasons why people may not want to necessarily step outside being outside, which is, just the overall climate and the environment, the violence that occurs, or the potential for, deleterious activities to be happening, just lack of safety. So economics is important. So, I mean, there's so many different things, but I'm just kind of throwing out just some ideas of what I, have. I remember this concept, and this is going to take me a minute just to kind of explain. I remember this concept that I was reading about, that in the motherland in Africa, and I forget exactly what a country, but they have these things called granny benches that are right outside of, I think they said, a few hospitals. And so these granny benches are places where these literally elderly mothers or grandmothers or whatnot sit, and people can come and actually talk with them. And it's just a very informal, and so they specifically put them outside of hospitals. I believe because there's a lot of, when people come out, they, still don't know what to do. They still don't know where to go. And so these grannies kind of just give them just advice, and not that I'm saying that we could completely duplicate that in the United States. And I still have to find that reference for exactly how they were able to implement that and all that. But I just thought that was just fascinating. And the reason why I say that is because my family home is at 36th and Broadway. And so we have a porch. And that is, it's my love. I love being on the porch of that house. And so my brother lived in that house. And so we call it porch therapy, just sitting on the porch and just being able to talk and just being able to just talk about whatever issues that are going on. We can't do that as much just because we don't feel as comfortable, especially certain times of the year when it's darker, earlier or whatnot, just because it gets, and it's just not the safest neighborhood like it used to be when I was a child and I lived there. But just the whole concept of just having someone to talk to, and someone that you trust, someone who is trustworthy, and I thought, maybe we can come up with this concept called brother benches or something. I don't know. I don't even know how to, and I don't know if that would work. But it's kind of like, I'm tired of responding to things after things have already happened, like when shootings happen and then everyone is coming around, the newscasters or whatnot are there after things have already happened, or after, a trauma or, some kind of devastation. What can we do before that? Trying to go upstream, trying to avoid things from even happening. So those are my few suggestions. I apologize for being so long-winded.
Can I add on something to what Dr. Rondo was saying? And that is the violence. When I've been involved in several surveys down in West Louisville. When you talk to families and mothers, like, yeah, park sounds like a great idea. First of all, they usually get overgrown. And I don't want my kids there. I worry about my kids. And I know there's several BBBT committees, in understanding. Dr. Rondo brought up exactly what I had just put in the chat. Economic development, job creation is critical to addressing some of the issues that are undermining the overall wellness of the community. So in actuality, you could put a clinic on every corner, and until you deal with those things, you are not going to change the trajectory in West Louisville. And by the way, Dr. Rondo, it's Zimbabwe, and I've actually seen them there, and they're amazing.
Okay.
Hi, this is.
Oh, sorry. Go ahead.
Oh, just really quickly, I wanted to go back to the air toxicity that Jerry brought up, as well as the link to what Dr. Rondo was talking about with cardiovascular health. I work for the Air Pollution Control District, and we're seeing a lot more studies that really emphasize the connection, particularly between particulate matter pollution and cardiovascular health. So that's another large risk factor, particularly in areas heavily burdened by particulate matter. And I know that we are, as a city, beginning the process of looking at our land development code again, and making sure that environmental justice is a key part of the land development code, and where we situate people and their proximity to roadways and other sources of air pollution needs to be sort of a key part of our review of that land development code, I think. So environmental justice more broadly, but specifically making sure that we keep in mind the health impacts of being located near those sources of air pollution.
Hey, this is Rebecca from the Public Health and Wellness. And I just want to say, just echo what you all have been saying, which is that health is not just healthcare, right? We all know this. It's a lot about the conditions that you live in. And I just want to plug that we've been talking about this for a long time in the Center for Health Equity in our Health Equity Report. We're working on a new one that we'll be publishing in 2021. With some recommendations. We have a community advisory board who's going to be helping us focus on what the policies and practices are that we need to transform, so we can kind of look at what are the things that we need that will actually help us get more towards where we want to be. The other thing I wanted to plug is we launched Healthy Louisville 2025, which is basically our community health improvement plan. And that focuses on 4 specific areas. One is the built environment and reducing pedestrian and bicycle deaths. Another of those areas is working with JCPS to improve school health and early childhood education. Another is around environmental justice. And then the last piece has been partnering, Kathy, I know you've been a partner on this, but around eviction prevention. So those are some things that we've been focusing on. Again, it's really important to make sure we get at some of these root causes of health. And Russ, yeah, if you shoot your email in, we can connect offline, and the same goes for anyone else. If you would like to kind of provide input, I'm happy to talk to you and get your feedback.
Hey, Rebecca, since I got you on here, I'm gonna put you on the spot a little bit, but not too bad, because you mentioned the Center for Health Equity report, which I think is critical data that a lot of individuals don't understand is out there currently, and it's been out there for about the last 9 or 10 years. Earlier in today's conversation, we were talking about coordination of efforts to see what exactly is out there currently that people can utilize to improve health and to improve wellness. Is there any room for, when we release this report, and then you talked a little bit about the advisory council, how we could better coordinate those efforts to allow people immediate and efficient access to services for health and wellness?
So Kendall, I think I guess the first question I'm hearing you ask is just how do we coordinate any health related efforts? Is that, I want to make sure I got it right.
Well, no, just moving forward, because there's been a lot of great ideas that have been expressed here today, but I think the launch of that 2021 report can provide a platform for how we can coordinate various different services that are offered throughout the community so that people understand what it is that we have currently, instead of reinventing the wheel to tell people, go here for this treatment or go here for this service. What are ways we could utilize the Center for Health Equity to help coordinate those efforts?
The one thing I will say is typically we don't focus on coordination of access to services or referrals. I know there are a lot of other groups in the community that focus more on access to services. I know United Community has been doing a lot of work on immediate access to particular services. What we're kind of trying to think about or focus more on would be more like policy efforts, or if that makes sense. Hopefully I'm understanding your question correctly, Kendall.
Because I think what's going to come out, a lot of this work that we're talking about today and over the next few weeks, is coordination of efforts. That's going to be super critical, because again, we don't want to have a lot of overlap when there's something that exists already. So I'm thinking one of the recommendations that's going to come out of this group is coordinated efforts to providing the community the communication they need to see what services are available to them.
Yeah, again, I think like we end up focusing more around the policy piece, and I think if coordination of resources and referrals, like that might be a great thing to bring United Community in on, because they've been really working on that service level access.
Any other thoughts around wellness?
This is Lisa. Just a quick comment, if I might. I wanted to, I guess, talk about just a little bit something that Rebecca mentioned, and also I think it was about land development and how do we reduce risk for our community members. Something I guess I would add would be efforts around revitalization. When we have community areas that are being revitalized, it might be an opportunity to also look at how do we do that. And this might be a little bit of a stretch, but something that came to mind to me a while back was there's an effort that's being made out west in our national parks to be able to create overpasses and things like that for migration. And so what I've noticed in my community is that when children want to get out on their bikes and so forth, it's difficult because they do have to cross roads and things like that. So I think we can be really creative moving forward to be able to create more walk spaces that will connect neighborhoods to green spaces, so that I know and again to Dr. Rondo, I'm not from the West End, but and so I can't really speak to what's needed there. But I can say that as a mother, I feel like I share some of the same concerns about child safety. And so I would imagine that that would be something that might translate across the community in terms of how do we connect green spaces to neighborhoods such that anyone on a bike or who's walking doesn't have to necessarily cross a major road. And then the second point that I wanted to just speak to briefly, because we haven't really talked about it, is and I talked with someone mentioned food and, you know, the expense of fresh food and things like that and exposure. We do have an opportunity with young women who are having children to really look at what they're doing during pregnancy to try to help with food. And the reason I bring it up is because there's so much research that's out there now that what women consume while they're pregnant has an impact on the foods that a child is likely to incorporate into their diet. So it might be something that's very specific, but since women's health is my, my go-to, it's something that's kind of important to me, that we kind of think about what we're doing with young women in pregnancy.
Kendall?
Yes.
Yeah, this is Keith. I just wanted to follow up on the planning and design and land development code. I wanted to make sure everyone is aware that Develop Louisville through Planning and Design will be having 3 community meetings talking about land development code reform. There'll be tomorrow, Saturday at 10 a.m. These are all virtual. Monday at 6 p.m. or at 10 a.m. and then Tuesday at 6 p.m. And there'll be an opportunity to folks to chime in with their issues concerning land development code, things that we can do to prevent some of the issues that we see now from happening in the future. And so just wanted to make sure everyone was aware that those are getting ready to take place.
What I'm hearing from this conversation that I think it would be really worth kind of playing with for us as a collective is to spend some time defining what is our vision of wellness. I've heard individual wellness, relational wellness, family wellness, community wellness, obviously physical and mental health wellness. I think in terms of developing overall and developing a strategy, I think having some visioning of what is it that we're trying to move towards would be really valuable in terms of clarifying.
Any other ideas?
Oh, I just have one more. This is Lisa. And we haven't just mentioned this population, but when I was looking through some of the documents that were online, there was a population forecast that talked about the increase that's expected of elderly women in the Louisville, Jefferson County area over the next 10 to 15, 20 years. So that might be a population in which we need to pay attention to, because elderly women are more prone to, dementia and Alzheimer's, and there's safety and abuse issues that could be prone in that population. And so we may want to add that to our list of areas that we need to consider. What do we offer as a community?
Older citizens or just women?
Well, just elderly in general, but I know at least on the population forecast that was in the documents online with the group, it specifically showed a significant increase in expected increase in population among elderly women in our area.
Okay.
And Michael, this is Kathy Hinko again.
Yes.
I expressed it kind of weakly earlier, but I'm really worried about lead poisoning as children are more confined in certain areas that clearly are more poisonous. And we have privately done inexpensive tests to see if parents can check their house to see hotspots. It's no one else. I'm just freaking out at how many kids may be getting, they're not leaving their homes to places that are guaranteed to be lead-free. I worry.
Kathy, I will plug that we're going to have an opening for the childhood lead prevention coordinator come up with Metro. So if anyone knows good candidates, have them check out the Metro job site. I think it should be posted soon.
Great. And you do great work. I'm just saying this is
Oh, no, I mean, I agree with you. It's an issue. Yeah, no, I think you're right, Kathy.
I'm going to come in for a couple of comments.
Yes.
On the lead exposure, I will say as a landlord, I'm interested to know what are the problems with lead poisoning today. We are now looking at 46 years since lead paint was outlawed. I know it's been a very active issue in housing in Jefferson County for many years. If you're going to sell a house, you're going to lease a house, things of that type, we've got certain things we have to do as far as, is there a lead exposure? Best of my knowledge, everything I realize part of it is covering the lead as compared to removal of the lead. But I'm interested in just what is the current issue? I know 20, 30 years ago, it was a big issue because of the kids chewing on the window sills and having lead paint on the window sills and things like that. Have we overcome some of that? Where are we with that, with the lead poisoning? I mean, with the lead exposure? Two other things. One,
well, I don't want to, I'm sorry.
Go ahead.
We have someone from public health here, but when you look at the maps of where low-income people live and where children live who are low income. They are extremely segregated. And you look at the maps of the oldest housing, which really lead was outlawed late 70s, but it didn't go away for another decade. People had lots of it. And that is where the exposure happens. I mean, sure, things now are built without lead, but there is a lot of lead left over from these very old homes where low-income people live, where it's not necessarily updated. And we should have a law that says a landlord must take one of these $8 tests and spray all around the unit and commit as to whether there's lead or not. Right now, landlords they say, oh, they can say, yes, there's lead, no, there's no lead, and they can say, oh, I don't know. And they say, oh, I don't know. When really they could know pretty cheaply and easily. We should have a law requiring that every landlord has to say yes or no, because now the testing can be done at least superficially so cheaply. That's a law I would support.
Well, I come back to my question was, is there a current problem? We can say, okay, there are older houses. Yes, there are older houses that go back 100 years. But
yes, that's in the Center for Health Equity report.
There have been measures over many years to diminish the impact of lead paint. And my question is, have those been successful? What's been the fruition of that? Where do we really stand as far as the impact of lead today? Another point that I wanted to raise was we keep talking West End. I keep coming back and saying there are issues on South Dixie. There are wellness issues in Fairdale. There are wellness issues in Okolona. There are wellness issues in Front Creek, and I can go around the rest of the county. But what I keep hearing is how it affects the West End. We need to be looking at all of this county. The other thing is, how do we change behavior of individuals? We can talk about, as an example, quality of food preparation. One of the things that I have noticed with some of my tenants over the years is, and the ones, particularly the ones that come out of the West End and move into a place, is that they do a lot of cooking in deep frying in grease. And I will tell you, the food they prepare, and I've had the opportunity at times to sample it, I love deep fried chicken that is made by but is it healthy? And when I can then see over a year or so the grease that accumulates on the baseboards in the kitchen and the roaches that come to that in order to eat that grease and the effects of that, knowing that has to have an effect on the individual. How do we change some of those? Some of them are cultural, some of them are just the way people eat. How do we get people to understand how you prepare the food, the type of things you prepare, the things that you eat can have an impact? Now, Dr. Rondo talked about cardiovascular disease and diabetes being two of the major killers in society today. Well, if we look at diabetes, a lot of the diabetes is based upon individuals who are overweight, me included, but a lot of that overweight around and results in some of the diabetic issues. So it's more important. We've got to come back. How do we get people to start exercising more, watching what they're eating? Some of these are educational things. We can't necessarily provide access to things, but some of it we need to educate. How do we reach those educational objectives?
I would just like to jump in and say something about that. At Center for Health Equity, like I understand what you're saying, and also we have evidence that focusing on policy level interventions is more effective than trying to focus on education. and behavior change, because a lot of times these specific behaviors are being influenced by other conditions that people are experiencing. And so I think there's a lot of evidence as well that when you focus on behavioral interventions for health, those effects are very time limited, right? So they might change for 3 months or so, but they don't have a long lasting impact. And so at Center for Health Equity, that's why we've really focused our strategy more on the conditions or the root causes of health and policy that we know will have an impact on a wider number of people, as well as kind of the choices that people have available to them. So I just wanted to throw that in there.
Well, and Rebecca, I'm glad you said that, because a lot of what piggybacks on that too is, you know, contemporary American society is very busy. I mean, I know COVID this year is kind of shaking things up, but in normal United States life, everyone is super busy doing whatever, working, going to school, working 2 jobs, raising families, so forth and so forth. So, you know, we live in a society of convenience as well. While we can make unhealthy choices for convenience purposes, it's convenience and cost for a lot of people. You know, if I'm running between class, what's quicker to eat and quicker and cheaper to grab, salad or a hamburger, or, you know, chicken or grilled chicken? You know, there's so many variables that go into that. So as we think about this work, think about our contemporary society in the way that everybody wants convenience, and they want it quick, and they want it hot, and they want it fresh, and all those other things that kind of go into our food choices. So just something to think about.
I just wanted to add in, I don't know if anyone else is feeling this way, but as I was listening to that discussion about personal choices and things, after almost 2 hours of talking about health and what we need to change, what we need to do, I felt myself becoming really overwhelmed with like, okay, so now we have, you know, and I'm a health educator, so I do a lot of that kind of personal individual training, but I guess I just had this overwhelming feeling of what it must be like when you're living with this all the time. If your environment is not where it needs to be to support you, you know, as Dr. Rana said, if you're living in a food swamp, it's all this stuff, you're not in a safe area. And then, and you know, now I need to be making better choices here. It's, you can really feel the weight of this and how it could really get to a point where it's just like that sense of overwhelming and almost immobilizing in what you can do with your choices.
We got about 8 minutes left. This has been another great discussion with the group. A lot of recommendations, a lot of ideas that you see here on the screen that Michael has put down. So I have another meeting at 3 o'clock that I have to go prepare for. So before I jumped off, I just wanted to thank everybody personally for, again, committing to this work, providing the invaluable input that you do in making the community better. I'll permit Michael to talk about next steps and things like that. But again, thank you all so much for your agreed participation, and thank you what you do for the community. So everybody, please stay safe, please stay healthy. COVID is real. We're seeing it continue to ravage our community, ravage our state, ravage our country. So take care of yourselves, take care of your family, and I will see you all in a couple of weeks. And Michael, I'll let you take it away. Thank you all.
All right. Thank you, Kendall. So at this point, our next meeting will be in 2 weeks, and we will go through a similar process, but we'll be taking up the issue of safety and we'll be coming up with recommendations for things that we need to do as a community to make life in our community safer. So look for an invite probably the beginning of next week, and feel free to stay in touch with us if you have additional comments, questions, recommendations. This is an ongoing document that we're going to continue to develop. as we work toward a written recommendation to leadership. So at this point, I'll try to answer any questions you have, and we appreciate the input from everyone. We appreciate your spending the past 2 hours with us, and if not, we will give you back a few minutes.
Michael, can I just?
Yes.
I'm so excited about this. I just have to share it with somebody. You guys were the most fortunate people that could do that with. You know, I'm at New Legacy Reentry Corporation, and we have individuals transitioning out of jail or prison, particularly prison, and we help them get back into society and to become viable citizens. One of my guys today found out that he has been able to register to vote, and he is headed to the polls.
All right.
And I'm so excited. And he hasn't voted since 1983.
Wow.
So this is his first time. It was his first time voting then, and it's his first time voting today. Yeah.
That's fantastic.
So I just want to share that with you. Thank you so much.
Awesome to hear that. Thank you. It's a good positive note.
Well, that's a positive note. Let me just say I looked at the Center for Health Equity, and lead is very much with us, poisoning children. And I remind everybody that we don't know how many children are poisoned because there's only a window where you can test for it being poisoned. Mm-hmm. And then it's already inside the child, affecting their behavior for decades to come. So I suggest everybody look at the Center for Health Equity report, and amongst other things, lead is in there.
If there are any
for the
physicians,
plug, Kathy.
if there are any physicians still online, does this affect the future generations? If there's a child that has been poisoned by lead, as that child grows up, is it possible for that child to pass on anything to his or her child?
It matters during pregnancy, Michael.
Okay.
So it impacts the child, and then it also impacts future pregnancies.
Okay.
This is Dr. Rondo. As far as I know, there's no genetic transference for lead poisoning. So no. Right. In terms of it genetically going to another generation. But of course, if someone is already in that environment, they're much more likely to, during pregnancy, and then maybe continue to be in that same environment after pregnancy. So.
There may not be from lead, but there certainly is from intense, continual stress, genetic changes that can be passed down to your children. So not because of lead per se, but let's say people who are poisoned with lead have certain behavior patterns, and those behavior patterns may produce stress that then does actually have, and it isn't just lead, any kind of these intense behavior patterns because of stress can form some genetic changes.
And then, just to follow up on Kathy's comment about those long-term changes that come from behavior that may be genetic, there's also the generational impacts that the educational attainment effects or the other types of behavioral impacts that might change that person's course of their life, and every generation thereafter will be impacted by those outcomes.
Yes.
And the reduced attainment potential for that one individual.
Yes. All right. Again, thank you, everyone. And we appreciate you so much. And we will see you at the next meeting. Bye-bye.